Welcome, everyone. We appreciate you all coming to learn about the future of industrial engineers in healthcare post-COVID. We're very privileged to have various industrial engineers in healthcare to give us insight on how we impact are crucial to the healthcare industry. And Professor Belson will introduce the speakers and move us forward.
Okie doke. Next slide, I guess.
Yes.
Who's our slide mover? Oh, there you go. Hey, Jim, thanks. Well, welcome, everybody. I'm David Belson from USC. We got an ambitious program here. We've got 5 speakers and 3 people from IISE, so it's kind of a tight schedule, but we wanted to give you a broad picture. This got triggered, at least to me, by I was speaking to somebody earlier this year from the Mayo Clinic, and they were an industrial engineer in the Healthcare Systems Society. And she said, "Why aren't there any industrial engineers on the East Coast, on the West Coast, participating? Aren't West Coast industrial engineers interested in healthcare?" And I think there are, and there should be more. So what we wanted to talk about today is why healthcare should be a consideration. If you're an industrial engineer, what does it offer, and why should you be interested? So there's 5 speakers besides myself. As I mentioned, I'm at USC in the Industrial Engineering Department. We also have Professor Xinyi Wu, who's also in the Industrial Engineering Department. Actually, everybody on this speaker list are graduates of an industrial engineering program. She is also in the School of Social Work as well as industrial engineering. We have John Franklin Sierra, who's with the LA County Department of Justice, Care, and Opportunities. He has a PhD in industrial engineering, and he'll talk about what he's seen. We're all going to talk a little bit about what our experience has been as industrial engineers in healthcare. Kaveh Azad is also from USC. He's at Keck Medicine, and talk about what he's seen. Will Taylor, also a graduate industrial engineer from USC, amazingly has moved to the other side, to UCLA, and he'll talk about that. And we'll have a Q&A period at the end, but we'll let each person talk about their industrial engineering and healthcare experience. If you want to go to the next slide. Oh, I went to back one. Okay, so briefly, I am, as I said, a PhD in industrial engineering. I have industrial engineering experience outside of healthcare. Initially, I was at Lockheed, later at IBM, Universal Studios, and EY. I've been working for the last 20 years strictly in healthcare, working with a lot of hospitals, rural hospitals, urban hospitals, the VA, San Francisco General, Cedars-Sinai, LA County, and other hospitals. And my main activity these days is a program director for our new program at USC, where you can get a master's degree in health systems management engineering if you want to have some training specific to this industry. So next slide. I found, at least for me, a lot of the healthcare industrial engineering is not a whole lot different from industrial engineering in other industries. Some of the basic tools, like a process map here, work just fine, even though it's not building airplanes or automobiles or rockets or whatever. This was from a recent project I did with students where we were looking at the treatment process for breast cancer. Also done many other hospital projects where we mapped out the process using your basic lean methods and Six Sigma. Lean is very popular in healthcare. Virtually every hospital of medium or large size has a lean program of one sort or another. Want to go to the next slide? A lot of the IE tools work really well in healthcare. This is a screen from a digital simulation of an emergency room. What we're often looking at, how do we speed people through the emergency room? How do you reduce the wait time? Everybody's frustrated with their experience in emergency rooms, and hospitals are desperate for help in terms of getting things to work faster and smoother. Oh, I wanted to mention, I was contacted a couple of weeks ago by Children's Hospital in Los Angeles. The person there in HR said, you know, this is a pretty big hospital. We've had an ad up for months for an industrial engineer, and nobody's applied. Nobody's applied to our industrial engineering position. There are industrial engineering positions out there going unfilled. Anyway, another industrial engineering tool, simulation, works great in hospitals. Did a project years ago at San Francisco General, where by modeling the flow through a colonoscopy clinic, we were able to increase their throughput by 50% with no change in staff or equipment, just a better scheduling process. So IE tools can have a major impact on what happens in healthcare. Next slide. Again, I'm beating the same drum, but again, the usual IE tools work here. Familiar with a fishbone diagram? Sometimes just because it's such fertile ground, just doing one of these tools in itself fixes the problem. Did a project a few years ago at a small hospital. They were having trouble with the handling of notes by nurses. And we sat down, a group of us, nurses, and did a fishbone diagram, and it became apparent what the problem was. And just by doing the fishbone diagram, it solved the problem. Suddenly things were working. So the usual IE tools work. It's just that hospitals, maybe it's the term industrial engineer, industrial, puts them off from looking at industrial engineers, but they certainly know nowadays about Lean, Six Sigma, and the need to improve their operations. As I'm sure some of the other speakers will talk about, healthcare costs are a big problem, and industrial engineers are ideal to control costs and speed up the process. Want to go to the next slide? One thing that's really true in healthcare, has been for some time now, is they have a lot of data. I'm sure your experience with healthcare, you go through a portal, you have telemedicine, doctors are taking notes, nurses are taking notes, all sorts of data come in from various systems, from radiology and pharmacy and what have you. So hospitals have a lot of data. And one thing I've read that some people think when there's a new technology, it takes maybe 10 years for that technology to be useful. Well, hospitals 10 years or so ago adopted electronic medical records, EMRs, and started gathering huge amounts of data. Haven't done as much with it as they could. And so data analytics tools, artificial intelligence tools are very applicable to healthcare, and they're very interested. They're all seeking, the larger systems are all seeking people with understanding of analytics, data analytics, AI, and so on. This picture here is from a current project I'm involved in, where we're using artificial intelligence and text mining to identify trends and safety incidents at a large hospital. So there's a lot of practical uses of analytics, as well as all the more traditional IE tools such as Lean. Many hospitals have Lean training programs internal. They give certificates in Lean internally within the hospital. And this is fairly new, and they're seeking more such help. Okay, next slide. I don't want to neglect supply chain. As we experienced during the pandemic, supply chain suddenly became a focus of everybody's attention, shortages of supplies. And again, the same industrial engineering techniques, economic order quantity, managing a supply chain flow, Kanbans, what have you. All those tools are very appropriate in healthcare. Hospitals, clinics, they buy a lot of stuff. They need to maintain that inventory. It's a big part of their costs. This is a picture from an emergency department on the right, and their warehousing. Supply chains become the attention of senior executives at all the major hospitals, thanks to their experience. So on to the next slide. So I guess one other thing I wanted to mention. So what do you need to get into healthcare? I think the others will mention this as well. They're complex organizations. Organizationally, leadership is complex with multiple chains of command. Healthcare is a people business. It's about people working with people. So communication skills are very key in healthcare. Be able to talk to people, understand what they're saying, and communicate well to them. Finally, another thing about healthcare that makes it an interesting and good career path is healthcare is everywhere, from the smallest town to the largest, every country of the world. It's a business that's really literally everywhere and anywhere. And so you don't have to be in Los Angeles, where some of us are, or a big city, rural hospitals, small towns, other countries. Healthcare is everywhere. So on to the next slide. I think the next speaker.
Yeah. So thank you, David. Appreciate your insight. Our next speaker is Xinyi Wu, and she'll be talking about engineering a better healthcare system.
Hey, good evening, everyone. I'm an associate professor in the School of Social Work and Industrial System Engineering. You may wonder why in the world have these two combinations. My PhD was in Industrial System Engineering. Actually, my journey in working in healthcare was starting with my PhD. While I was doing my master's degree, I was in the center for I was in University of Wisconsin in Dr. George Box's Center for Health for Quality and Productive Improvement. We were working on agriculture machines as well as car cylinders, trying to improve the quality for those machines. I worked there during my master's and feel like I'm totally lost. This is not a business I want to devote my career to. So I took a break, and after I went back home, my grandparents were sick, so I was the caregiver with them in the hospital. There, I found where my passion is about. There were so many troubles in the healthcare system. I feel like as an industrial engineer, this is somewhere I can contribute to. And I hope today's talk, you will also see that we need a lot of help in healthcare system. And we are calling for you, industrial system engineers, to consider your career in healthcare because it's so meaningful. It will help so many lives. Next slide, please. So this is a map that tells you why I'm in social work. Healthcare has a lot of disparities. The disparities you all experienced during COVID. Minority populations are more likely to contract more severe COVID, as well as more hospitalizations and more deaths. And that reflects not just for the COVID, but for many other conditions. This map shows the different life expectancy for by census tract. So if you're lucky to be born in the area where it's blue or dark blue, you may have like life expectancy of 80 years and above. Here below, you can see that the life expectancy is as high as 97.5. While if you are unfortunately in the areas where it's red, dark red, the life expectancy can be as low as 56.9. So on average, there are 20 to 30 years differences in life expectancy. These health disparities is what we see as industrial engineers, that you are not only help to make people's life better, but also to make a more equal society. So that's why I want to show this map to say that you could contribute a lot to make a big difference. Next slide, please. So healthcare has three great areas where it's creating value for people. Access to care when people need it. Providing quality care treatment to help them improve their health conditions, as well as offering in an affordable way so people are not overburdened when they are seeking care. This, however, is called the iron triangle of healthcare because this iron triangle is proposed by William Kissick. In his theory, he posits that in the contemporary healthcare system, these three components are essentially competing aspects of the healthcare delivery process. If if you're lucky, you can improve at least at best 2 of the 3 and not having the third point suffered. Let's give some data about each of them. For access, in this country, 1 in 10 people have no healthcare insurance. So healthcare becomes very difficult to access for these people without health insurance. In terms of quality, every year, about 250,000 to 500,000 people are died because of medical errors. For cost, our per capita expenditure is about $11,000 per capita, which is 10 times more than the world average and higher than any other country in the world. So to improve, we must improve at least one aspect of it. But if we improve one aspect, the other 2 aspects could suffer. If we try to improve 2 aspects, the third aspect could suffer. Is that true? Third point, please. I believe it's not true. I believe with IE, with your contributions of your technical skills as well as analytical skills and system perspective, there is a hope. I strongly believe we can contribute to creative and technology facilitate solution to achieve the triple aims. This iron triangle can all be improved with improving efficiency, where we can reduce the cost, and with efficiency, you have to have a better system so quality can be improved. And with both, resources can be relieved to increase access. So next point, please. I believe the more efficient way we can make the system is, the better the care is for everybody. Okay, so next slide, please. It's easier said than done. Healthcare system is complex. Healthcare system involves multiple dimensional structure. Often we see doctors or hospitals, but not only those 2 access points, there are diagnostic systems, there are insurance companies managing the benefits and the payment. There are pharmaceutical companies from pharmacies provide treatment options. We also have different stakeholders, including doctors, insurers, payers, patients, and so forth. There are multi-phase interactions among them. The process is highly interconnected, yet is highly regulated, and it relies on a lot of collaborations. Let's take a look in the next slide for Tommy Trojan's journey. If you know who Tommy Trojan is, it's a mascot at USC. So this guy, this iron guy, is Tommy Trojan. So I'm just using his name as our example here to illustrate the complexity of healthcare. So Tommy Trojan, he has onset of a stroke. He felt numb in his face and his hands and his arms. And his vision is suffering, so he called his wife to call the emergency room. His wife called the ambulance to take him to the hospital, while she has to look up to see which hospital to go to, because they just recently changed their health insurance. So if they go to the wrong hospital, they have to pay a lot of out of pocket. If they are going to the hospital, it's not in network. Okay. So when Tommy Trojan get to the ER, the emergency department, fortunately, he was stabilized, but he was deemed that he needs hospitalization. So the inpatient team need to work to get the room ready, get the hospital ready, get the nursing team ready to admit Tommy Trojan into the hospital. Then they decided that he needs to have a surgery. So they contact their contracting doctor, Dr. Good. She's a good cardiologist, surgeon, but she's not part of the hospital. So need to work with her to bring her in to do the surgery for Tommy Trojan. While Tommy Trojan will stay in the hospital, the nurses were providing him medications, but his wife caught that he was given blood thinning medications. Yet his surgery is scheduled for that evening. Luckily, she talked to the nurse, and the nurse realized, oh yeah, she overlooked that the doctor's surgery was scheduled for the surgery this evening. Otherwise, there could be a devastating outcome for Tommy Trojan. So after he successfully finished the surgery, he stayed in the hospital in the intensive care unit because of his condition, and he was on the floor for a few days. After that, he recovered, so he spent 2 more weeks at the hospital to complete his recovery as one under the care with the inpatient teams. Then, when he was well enough, he was sent back home for ambulatory follow-up. Then he visited Dr. Good in her clinic and also participate in a rehab program, which he needs his insurance to cover the rehab program. And then after he got better, he went back to his primary care for his regular checkup by his PCP. So this is the process of the patient flow from Tommy Trojan's perspective. Let's go to the next slide. To make the care available for him, there are a lot of collaboration and teamwork within the hospital systems, and not even talking about beyond the hospital systems, such as in the ambulatory or primary care doctors. There's inpatient, there's different lines of services, surgical services, which is part of the hospital, but not, for example, Dr. Gu is not part of the hospital. And there's inpatient service that they also need to coordinate. There are many units in the hospital. There are many different work groups need to make this care happen for Tommy Trojan. There's pharmacy group, there's lab group, there's radiology group to take pictures to diagnose his conditions. There's also nursing teams, OR teams, palliative care teams. If he needs it, luckily he didn't need to. There's a specialty consulting group like Dr. Good. He also needs case management because he has also other conditions. So this case manager need to make sure that his case is well monitored. And he might need transitional care to go to the ambulatory afterwards. And there's also the family and patient experience group that work with him and his wife concerning about whether he's receiving the right care with medication issues. And there's also, of course, food services and cleaning services that need to take care of him as these hospital experiences. And during this process, there are multidisciplinary rounding to ensure that he's receiving all the care he needs from different teams, these very complex teams of people. And each hospital has their own practice model, which also affects how he receives his care and based on the levels of care he needs and how his data is being managed during the hospital, as well as to transition from his old history, as well as after he left the hospital, how to share the data with his primary care and Dr. Go's office and so forth. So you can see the structure of healthcare is very, very complex, involves cross-functional work groups, needs high-level team process and collaborations. As Dr. Belson mentioned, this is people business. To move patients from in and out of the hospital, there are so many complex processes need to be worked through. So let's move the next slide, please. So inevitably, you can see a lot of waste in this process, many paperwork in different parts of the processes. And if you're familiar with these terms, you can see these different categories of waste that Lean is trying to reduce. There are a lot of opportunities in the care system where all these type of waste are everywhere. You see the defects, for example, in the X-ray tech, you had to re-enter request because of the wrong side indications for a surgery. For overproduction, admissions paperwork have many redundant pages in the patient's packet, which not only is overproduction, but also reduce efficiency and creates more confusion for people. there's a lot of waiting time, or our team needs to wait for case to begin, and they are not free to do other tasks. So how to schedule in this very complex system. And also, for example, not utilizing the talents that people are spending time for clerical work instead of value-added task. Also, you can see patients admitted need to be waited to transfer between different units from ER to inpatient to ICU to taking X-rays, taking scans, CT scans, and so forth. A lot of transport. They we also see in the supply chain, you can see some expired supplies because of excess ordering. For pharmacy tech may spend time looking for multiple places for particular medications to provide to patients. And there's extra processing for the nurses to see different forms in the chart. So you can see waste everywhere in this process. So I explained the process of a complex structure to work with, a very complex process to move patients from in and out of the care systems, and a lot of waste in the healthcare. So what can we do? So in my research, I research healthcare delivery. So I have done work to improve care coordinations. For example, I work with the county to work with doctors and hospitals to make sure that chronic illness patients are being provided good care, a care model that's more appropriate for chronic illnesses, and that they can improve their efficiencies during the care processes. For example, one of the technology I developed was to use patients' voice recognition system, so patients can be assessed prior they go to the hospital for their mental health conditions, so their care teams can be prepared to address them. We also work on the information system, so providers have easier time to chart and spending their time more on the care instead of charting. We also work on the care coordination, so the information system that we built will automatically queue different care teams based on patients' needs. So if you're interested in healthcare system, you may work with doctors and hospitals by providing them with the better operations and the tools and the data they need to transform the practice to be more efficient, better quality, and safer for patients. You can also help improve efficiencies in the healthcare system by eliminating waste, as the many type of waste I just mentioned, and promoting better decision-making. Wrong decision-making is a big waste. Okay, so how to use data, how to help providers identify which patients are in need of what type of care and at what time and what timing. Many hospital systems, healthcare systems are providing care for people who have access. Doesn't mean that these are the people who have needs. Okay, so a lot of health disparity we see in the first map. So that's something I would like you to think about. How do we provide providers to better address care needs and reducing frauds and abuse? We can also work to help people to be active partners in their own healthcare. That's one of other projects. One of several of my projects are related to that, to help people to become more active partner in their, to be empowered for their decision-making, to be empowered for their self-care, to use technology to understand how to manage their health conditions better. We can also provide educational tools to help patients understand what are their needs, when they should access care, how to understand and expect proper care. So they will become part of the value system for healthcare. We can also use data analytics. As Dr. Belson also mentioned, that there are a lot of data available in healthcare system. Earlier in my career, I also help to evaluate how to use information system to develop better electronic health records, to develop better pharmaceutical exchange, information sharing, and so forth. And now we have data. So what? can we use the data to establish ways for doctors and hospitals to provide better care, and therefore they can be paid by not just the work they do, but the quality of the work they do, and that really help patients. So that's another thing, another areas I think a lot of potential for industrial system engineers to do. So next slide, please. Of course, nowadays, if we don't use AI, we are outdated. So I use machine learning to help understand how do we utilize the data to identify which patients needs better care and what frequency of care needs. And to prepare for this talk, I also use AI, the chat GPT, say what can industrial engineers do in healthcare system? So we say industrial and system engineers play a crucial role in improving efficiency, quality, and productivity in healthcare setting. And the ChatGPT say these 8 areas where industrial engineers can contribute to the healthcare industry, such as process improvement to make this process less waste, more efficient. We can work on the supply chain management. So things are there at the right time, just in time. We can help doing the facility layout and design, so providers are spending time at work more efficiently. We can use data analysis and decision support to help make better decisions, improving quality and patient safety, and also health information systems to improve health, patient quality and safety. We can design, if you like to design. There are a lot of opportunities also to design ergonomics and human factor devices and workstations for providers. Or if you're interested in performance measurement and metrics, there are many opportunities to benchmark, to improve, to do analysis to improve performances. So by leveraging their skills in process improvement, data analysis, and system optimization, industrial systems engineers can help healthcare organizations deliver more effective, efficient, and patient-centered care. Next slide, please. So this is my last slide. Again, I hope today's quick talk help you understand healthcare is a complex system. It's a system where you could have a lot of contributions to. If you see yourself in the system to help ensure smooth and efficient patient flows of individuals, not just patients, individuals, providers, patients in this system to make they can more efficiently deliver high quality care. Or if you see yourself in optimizing the system's processes to enhance the overall experience and outcomes for people. Or if you see yourself establishing the more well-functioning and seamless system in paramount to provide optimal healthcare services, healthcare needs you. There are lots of opportunities for IISEs to improve efficiency, throughput, capacity, safety, quality, patient experiences, data analytics, technology, innovations, implementation. They are calling for you. And back to my master's working in the Center for Quality and Productivity Improvement at University of Wisconsin Medicine. That center now is fully devoted to improving healthcare. Thank you.
Great. Thanks, Sinye. Next slide, I believe, is John Franklin. Oh, sound is not good.
Is that a little better?
Yeah, now it's good. Good.
Okay. I just switched my microphone quickly. Zoom can be a little weird with me sometimes, but I'll start over. So, hey everybody, my name is John Franklin Sierra. I'm a principal analyst with the Los Angeles County Justice Care and Opportunities Department, and I'm here to talk about just a variant of healthcare here, engineering a better safety net health and social services system. Basically to talk about how even when you talk about IISEs and their involvement in healthcare, there's even more to it than just hospitals and clinics and healthcare networks. There's a very large public health and social determinants health angle to the value we can add to all of this. I'm also going to apologize in advance. I do not have any visuals with these slides. I'm pretty out of the game when it comes to delivering lectures, and so I'll do better next time. But I'll try to just use my words to create pictures with words as much as I can. Next slide.
Words are good.
Just very quickly, I have a PhD in industrial and systems engineering from USC. I also have a master's in health systems management engineering from USC. So the program that Dr. Belson mentioned, I have the master's from that program, can highly recommend it. I mentioned now I work for this new department called the Justice, Care and Opportunities Department. It's a brand new county government department that was created last year, focusing on improving prevention, diversion, and reentry for folks who are involved in the justice system. And I'll talk a little bit about how it got interesting journey to get to that point. Prior to that, though, for about 5 years, I was with the Los Angeles County Department of Mental Health. I worked for the director of that department on a variety of different strategic change initiatives. And for those who don't know, the LA County Department of Mental Health is the largest public mental health organization in the country. Very, very, very big mental health operation. Next slide. So a little bit about LA County that I think is important to this, just what I'm going to talk about. It's the largest county in the US. It has about 10 million people. That's bigger than 40 states. So LA County is almost, it's really a state if you look at it that way. Nearly 40% of the county is enrolled in Medi-Cal. And for those of you who don't know what that means, in order to be enrolled in Medi-Cal, you have to meet certain requirements. In order to be eligible, you have to be below a certain income threshold. You have to have certain disabilities, and that's a pretty substantial amount, though. It's a very high percentage of individuals who are enrolled in Medi-Cal in the county. When you look at those who are youth, it's 55% of youth under the age of 18 enrolled in Medi-Cal. So very, very, very large percentage of the county relies on public sector safety net, health insurance and health systems, publicly funded health systems in order to pay for their necessary care. Some more looks at this. You have about 2 million people in the county that are below 138% of the federal poverty line, which is one of the markers of eligibility for enrollment in Medi-Cal. You have about 50,000 unsheltered individuals experiencing homelessness in the county, nearly 25% of whom have significant mental health needs. That's compared to a general population that has somewhere around 4 to 5% significant mental health needs. So much higher prevalence of mental health needs in the unsheltered homeless compared to the general population. And then you've got on any given day, 13 to 14,000 individuals in the county jail system. Over 40% of them have significant mental health needs. One of the jails, Twin Towers, is unfortunately considered to be one of the largest mental health institutions in the country. About 4,000 inmates there, almost all of whom have very serious needs. Next slide. So when you talk about the safety net, delivering health and human services to very, very vulnerable individuals, there's a very complex array of social determinants of health involved. And, I bring up these social determinants of health because just like we talk about disease or ailment or injury that might drive someone to healthcare, social determinants of health are also actually a very, very fundamental driver of healthcare needs. In fact, they are really one of the most fundamental drivers of the diseases and ailments that lead people there in the first place. If you think about it, you can break it down where whether it's lifestyle, diet, exercise, smoking, drinking too much, a lot of those are kind of like the core things driving quite a bit of morbidity and mortality in this country. But also things like housing, poverty, justice involvement, education or lack thereof, employment or lack thereof, and inequities, as Dr. Wu mentioned, are very, very present in our health system, right? And so you have this complex array of social determinants. You have very, very complex policy landscape and landscape of funding, or as I would call them, constraints. You have a very, very complex array of organizations that are, have a position of leverage, have the ability to make a difference here, are sometimes, if not at odds with each other, just not always on the same page, right? They're not always rowing in the same direction in a system this complex. And so you have various needs in the safety net and, limited public funding to address them. And the result is a very complex system that's pushed in many different directions at once. Next slide. So where do IISEs come in there? This, I think, helping and designing systems and programs to make a difference in this space, it's all about complex systems designed within constraints, which is something I think we're really, really uniquely positioned to add value to. We're equipped with lots of tools, as Dr. Belson and Wu have mentioned, to understand complex systems and processes, workflows, supply chains, organizations, understanding their structure and behavior, and try to find ways to implement optimal solutions to address some of those system challenges. In a complex system like this, with so many different kind of either competing or just different interests and pressures and pulls in many different directions, the ability to offer a strategic direction is incredibly valuable. To be able to say, hey, based on data, good logic, maps we've done where we try to really dissect these problems and understand the key drivers of them. This is a direction that we think better odds than not, it is going to provide value and is going to incrementally affect the kind of change that we need. And so that ability is the strategic value that an IISE can bring in a system like this is immensely valuable. And then lastly, I'd be loath to not to point out that the impact that you can make working in systems like this, you can help some very, very, very vulnerable people and make a huge difference in their lives, applying your talents in this space. So next slide, I think this is my last one, was just give us some examples of projects I've worked on in this space and, where I've tried to apply my IISE mindset to those projects. Although at the end of the day, I try to just carry with me the maximum to be useful, whether, whatever tool, whatever technique, whatever challenge, like just be useful. I think that IISEs have an incredible ability to just be generalists and just be generally useful in so many different problems and situations you'll encounter in these spaces. And so I like to say that because, you can sometimes just get kind of stuck and tied up on like, am I using the right methods? Am I using the right this? And it's like, okay, just try to be useful. And you'll make quite a difference even with that simple mindset. A few examples though. So the first ones I think are really more traditional IISE project. One of the first projects I worked on at DMH was looking at their, they have a mobile crisis response program responding to folks experiencing some kind of behavioral health emergency or suicidal emergency in person. I looked at data on their responses, broken down by response times, when calls came in for service, when people were dispatched, when they actually arrived on scene, when they concluded, to be able to model arrival and service times in that system, and created an agent-based simulation model to look at the lining up of the staff, how they were scheduled versus optimally how they could be scheduled to reduce response times. And I showed with just, some changes in staffing, if they were able to, obviously, you have to convince people to change their schedules, right? So it's not just about mapping out the right optimal solution. There's a human element too, but I showed, hey, if you could convince people to consider some different schedules here, you could almost cut your response times, your average response times in half by just adjusting schedules. And so that was just a cool exercise in and of itself, where I got to use some very traditional simulation modeling to do this. Another project was looking at the flow of clients through different safety net treatment and housing bed programs. Beds are really interesting healthcare resource. They're a pretty fixed resource. They're a very capital and labor intensive resource. And when people get stuck in them for too long, it can cause all kinds of issues in a system at the macro level. So we were seeing issues where people were getting stuck in beds longer than they should be because of a lack of availability of places to step them down to. They weren't ready to like be discharged back home per se. In this case, we were looking at people with pretty significant mental health needs where, you know, there's ideally just a kind of a decanting process that's ideal for those individuals where they're not just going straight back home. And so we were looking at utilization and flow patterns across several different levels of care and bed levels of care. I did that project also one of the first things at DMH. I'm still getting called on in projects today, even at my new department, where I'm like the beds person because I understand, you know, beds and know how to count beds. And that might sound so mundane, but it's one of those things that can get surprisingly complicated in healthcare, actually, in some places. Another project, many of you may not know this, but there's now a nationwide number 988 for behavioral health emergencies. So you can call 911 for physical health emergencies. You can call 988 for behavioral health emergencies. That launched in July of last year officially, and it utilizes the National Suicide Prevention Lifeline Network, which already existed. But when we found out about this new 988 number coming out, we found out about this a few years ago. We threw a huge project together, and I was the lead for it at DMH, called Alternative Crisis Response, to try to better prepare the system for, you know, folks calling 988 with the hope that whether they're calling for, you know, a suicidal related need like they would have called the Suicide Lifeline for, or any other kind of behavioral health crisis, maybe they have a loved one who's experiencing some kind of a psychiatric break. Maybe they have somebody who, you know, one of the sad things is many times, you know, if you rely on 911 for those things, it's not an EMT who shows up first, it's law enforcement. And you may have heard on the news, you know, situations where someone in crisis, law enforcement shows up and a tragic event happens of some kind, and some people have even gotten killed that way. So there's a huge push to rely on a different system to try to meet the needs of those individuals in crisis. And so there's a huge undertaking to try to understand this very big system, this very complex system, and the interconnections between 911, 988, emergency medical services, non-EMS crisis response resources, hospitals, but also specialized psychiatric crisis stabilization units, and how we could use some of those alternative resources a little more effectively and efficiently to meet the needs of folks in crisis as an alternative to law enforcement and other kinds of traditional emergency response systems. So very, very big system design and system planning undertaking that thankfully I've handed off to like a big old team at DMH now to work on all that work. And the last project I'll mention is something I'm working on in my current department, where we're trying to develop a better system to provide services and supports to folks who are released pre-trial, meaning they've either been arrested or cited or charged, but not yet convicted of a crime. And you know, many of these individuals will either be released on their own cognizance or maybe released on bond or bail. And the social determinants of health and whether those are their needs are met or not can actually be often a really critical factor as to whether they, well, worst case, whether they recidivate back to the justice system or even just fail to appear in court. If someone, if you think about it, has unmet mental health needs, they may not remember their court date. They may not even remember that they've been charged with a crime. Many of these folks need a lot of assistance making their way back to these court appointments, and a pretrial services system, a more unified pretrial services system that really, in a disciplined and intentional way, tries to address these folks' needs at the time of release can make a big difference in their lives from both a health and a criminal justice standpoint. So that's a small sample of like some of the work that I've gotten involved in the space over the last several years. And, you know, again, where I think is a great example of where IISEs can bring tremendous value to a more public health type or more macro health type environment, definitely to an environment where public service is necessary. It can be an incredibly rewarding career and something I really encourage IISEs to consider public service when they're considering their career options. So with that, thank you. Great to talk to you all.
Excellent, fascinating, very worthwhile, John. That's great. It's not an area of healthcare that everybody gets involved in, but it's certainly worthwhile. Yeah, great. Okay, next slide. I believe it's Kaveh, who's got a totally different element of healthcare. But thanks, John.
Thank you, Dr. Belson. Good evening, everyone. My name is Kaveh Ushmandaza. Delighted to be here sharing my perspective on IE and healthcare tonight. I'm the Director of Operating System at Keck Medicine of USC. In a few minutes, we're going to see what operating system mean in healthcare and how does it relate to industrial engineering. But for now, let's take a quick look at Keck Medicine of USC. If we can please move to the next slide. Downtown LA and surrounding areas, 4 hospitals, close to 1,000 beds total, more than 100 clinics, 4,000 employees. So large health system in Los Angeles and some of the surrounding areas. And also, as you will see on the next slide, we are very proud of our history of innovation and what has been the birthplace for many innovations, as you can see on this slide, and continues every day and every patient. If we can go to the next slide so I can share a little bit about my ISI journey, and which has been fairly diverse between auto manufacturing and aerospace, research and development, and design and engineering. And for the last 15 years in healthcare and higher ed at the same time. And Keck is where I'm today in leading several improvement initiatives and teams. But when I reflect back at my own career as industrial engineer, I see after I received my master's degree, I can see some common threads that took me from quality engineering with Honda and Boeing and R&D and design to healthcare in such a highly respected organization such as Keck. These common threads for me happen to be process improvement, Lean, Six Sigma, and quality. But the point is the toolbox that I've learned and I practice on those different industries. Over time, I was able to apply and customize to healthcare environment with different stakeholders and with different cultures. When I was at research and development or aerospace, for example, I was passionate about leaning out the processes, making them more efficient and more simple. And I took the same core concept and took it to healthcare. So I think it's very important to remind ourselves that there are few IE key focus areas that can apply to any environment, and definitely our patients, our population of patients and families, and the community at large can benefit from those individual talents and passions and the strengths that IE has to bring. That said, obviously, IE has a very diverse portfolio of tools and topics. So I have picked a few as the core to go over and see what are some of the similarities or what are some of the opportunities that IE professionals can practice in healthcare. As we will see on the next slide, and we have heard from other presenters tonight, healthcare is a very complex environment, and also industrial engineering is about solving complex problems, right? So we can, if you think about an operational research model with so many variables, so many constraints, so many assumptions, that's a very complex model. If you think about a queuing model that has several servers, arrival times, process times, complexity of the systems, that is a complex system. So if you have the appetite for that kind of challenges and dealing with that complexity, healthcare will be your place. Tonight, again, we have heard several different perspectives. The one that I was recently reading an article about is the complexity that the payment model has in healthcare and what's called the value equation. As you can see, it's multiple factors that play a role in the value and what's perceived as the value by the consumers and the payers. It has the quality of the care, what the outcomes are. It has to do with what level of service the patients and their families experience. And of course, it has to do with the cost at which this service and quality is delivered. Nowadays, thanks to availability of information, patients have a higher responsibility in their decision making, and also they have a higher visibility to what the costs are. And at the same time, as you can see on the third element here, we can see that these overall reduction in the healthcare spend per patient. So that in itself speaks to the complexity. I was reading an article earlier this week from Kaufman Hall that the statement that stood out to me was the median year-to-date operating margin index for hospitals slightly improved in April to, you ready for that, to 0%. So the margin improved in April to 0% according to statistics that they have. So that is the environment and the scarcity of the resources that we are talking about in healthcare. And of course, that is something that industrial engineering has several tools and several approaches to address, as you've seen in your coursework, in your experience as industrial engineers, for those of you who are practicing, and of course during the presentations tonight so far. Also, if we can move to the next slide, please. What we can agree on is, if as industrial engineer, if I tell you that there is a resource X, whatever that resource is, which is only 55% utilized, but you still have to wait several weeks in order to access that resource. On the surface, it may sound like a good question for a final exam, but in reality, what it is the average percentage of operation room utilization across the country, as well as the wait time for the patients and for the physicians to book that operating room. So definitely there is an imbalance that is the core of industrial engineering practices of operational research, queuing theory, and how to best utilize the models and how to optimize that. So I want us to think about this great strengths that IE has in this area and how can we make these improvements happen in an area of need. Which takes us to the next one. Next slide. The alignment. Industrial engineering is all about alignment, right? So part of the key philosophy of industrial engineering is not only individual processes and individual functions needs to be optimized, but the overall outcome of the system needs to be optimized, right? So we have heard about that, and we have heard that how that's very important in the overall deliverables to the customers and the value equation. The picture that you see on the top shows one of our improvement workshops a few months back. What I want you to notice is how many steps were involved in that process. And more importantly, how many stakeholders, how many individuals representing different areas are there, right? So the alignment becomes key. And also the equation below that kind of is a summary of what I was talking about is when we want to have the results of our solutions in place and sustained, we not only have to think about the quality of the solutions, how well it sounds on paper or on a simulation, but how much acceptance and adoption do we have from different stakeholders? And just looking at that picture, which is only a representation of what we experience in healthcare from day to day, shows that how important it is to work with the different stakeholders and make sure that their voice, the voice of the customer, the voice of the process, are all incorporated into the solution in order to have the results that are important. And that is a core part of the industrial engineering. So is the standardization. That is a topic of my next slide. So just to give you a little context of what we're talking about, we know that we have a lot of probability, variation, and statistical tools in industrial engineering that are discussed. And if I tell you that in one of our hospitals, for example, we have something about 90,000 patient days, that means number of the patients in the hospital times how long they're staying. So that's a large number. And during each of those that the patient stays in the hospital, roughly we have 20 or so opportunities that the patient's identity needs to be verified, meaning that their names and their date of birth and other identifiers that are usually on the wristband need to be identified and verified in order to receive care, either blood work, receiving a procedure, receiving medication, going from one phase of care to the other. So do the math of 90,000 times 20 and think about all the probability models and variation reduction approaches that we have learned and we are learning in industrial engineering. We are talking about an industry that if you have a deviation of 1% or even 0.001%, the outcomes and the consequences could be catastrophic and could be very, very costly, right? It means that delivering the wrong procedure or medication to the wrong patient. So one thing that industrial engineers are very fluent at and we are very good at is how to identify the opportunities for standardization by which we can reduce, unfortunately, not yet fully eliminate the chances of those errors happening. And that standardization could be, there are a few examples here. As you can see, it could be a standardization on approach, how we are aligning different processes, could be developing and implementing checklists, as you can see, the sample on this slide, or could be even the setup of the rooms. So different caregivers, different stages of the process, they will experience the same thing. And by standardization, we aim to eliminate, if not reduce to the extent possible, the errors and outcomes. And the other core element of industrial engineering that I would like to highlight here is industrial engineering is all about measurement and outcomes, right? So needless to say, that's a key part of our engineering. You see a couple of samples here. One is the template that we use at CAC leadership meetings to look at our ongoing and monitor the ongoing measurements across different elements of operational, clinical, and financial systems. And also you see in a snippet of publicly available data that how different hospitals compare together across different dimensions of clinical and other outcomes. So the point here is, without boring you with all the details, is measurement of outcome is the core of industrial engineering. And if you are enjoying doing that on the science of measurement, slicing and dicing the information and data and see what knowledge and what level of actionable information could be achieved through that, you will love healthcare and healthcare will love you as well, because that's a very nice combination. On the next slide, you will see another core element of industrial engineering is being highlighted, which is what we call systemness, right? I already alluded to that industrial and system engineers promote system approach. And that's a unique perspective that I believe industrial engineers can bring to the table. In healthcare, you're going to work with the best technology leaders. You're going to be surrounded by the world-renowned surgeons that perform magical clinical care. And you're going to be working with a great group of the clinical leaders that they know how to deliver to their patients, their families, the staff. They are all the heroes and the superstars of their own processes. But what an industrial engineer can bring is that overall system perspective and how these pieces will work together and how these pieces can support each other and can support the continued delivery of the care for all the different stakeholders. Again, what you see as a snippet here is how we have defined the systemness at Keck Medicine of USC through our Keck operating system. And the details aside, it talks about different approaches of the healthcare and how all those processes should come together, and the overall optimization is what we are looking at. The next slide, which I believe going to be my last one, is what we have heard again from our esteemed presenters this evening a few times, is industrial engineering is all about people. So on the top left corner, you see Mr. Frederick Taylor's picture, which is arguably the father of industrial engineering. And also at the bottom, you see Dr. Edward Deming, one of the pioneers of quality management and continuous improvement, the field of industrial engineering that I chose to practice. I don't think many of us will refer to Taylor as a mechanical engineer, although he was a mechanical engineer. And I don't think many of us will remember Dr. Deming as an electrical engineer. He was an electrical engineer. I think what resulted in their outstanding job and the legacy that they left behind is their ability to work with people, to understand their pain points, to develop solutions with them, and to help them to together to enhance those solutions. And that's what's been left as industrial engineering and quality management. That's exactly what the need and a strength of the healthcare environment is, the environment that people work with people to deliver for people. And again, if you see yourself someone who enjoys that kind of work with people, understanding what their pain points are, and partnering with them to developing solutions, healthcare welcomes you. And as we've heard, healthcare has lots of opportunities to offer immediately and in the longer term. So with that, Dr. Belson, that concludes my presentation. And
okay, thanks, Kaveh. Excellent, very good overview and other perspective. Our next and final speaker is Will. Did you want to run your own slides, or can we run the one in this deck?
Yeah, I'll share my screen now just so because of the formatting. Hi everyone, my name is Will Taylor. No relation to Frederick Taylor that I'm aware of, but I wouldn't deny it. So I know this is a USC crowd, and I went to USC, but I do have to rep my.
Yeah, we're very congenial here, even though a different school.
So I did go to USC for my undergrad under Dr. Belson. I then went and got my MBA a few years later at UCLA, only because it was closer to work. I want to clarify that. But thanks to the senior design project as an undergrad, I had the opportunity to interview and work with Gulfstream for a few years down in Long Beach, where we did final phase assembly and a lot of repair and overhaul. And that was a really exciting role for me for a few years. The first airplane that we delivered was a corporate jet for Nike, which they asked to have painted like a shoe all the way down to the tread pattern on the bottom of the airplane. And really enjoyed that work. Highly customizable, but low volume. We use a lot of IE tools to shrink turnaround times. We cut about a month, or about a 30% off of the delivery time for an aircraft. But after a few years, those aircraft became kind of just obstacles for me to walk from one end of the hangar to the other. And I realized that aerospace may not have been my passion like it was for a lot of the folks that work there. And so I looked to get some different professional experience, and had an opportunity with Eaton Corporation, which is a huge diversified industrial, but the location that I was at made hydraulic valves for aircraft. And whereas Gulfstream was highly customized, low volume, Eaton was high volume, zero customization. We shipped thousands of valves a month, and they had to work the exact same. Little did I know that would prepare me for my next step in healthcare, which is both high volume and highly customized, because no patient's journey is going to be the same. And as you'll see with some of the numbers, and you saw in Kaveh's presentation, we have really high volumes in healthcare right now. And I will say that my only experience has been at UCLA Health, which is a large academic medical center. And there are a lot of different ways to apply lean in healthcare, but my presentation will really focus on my experience. And just like Kaveh, we're mandated to give you a few slides about our own organization. John, I can't take credit for these. These are all marketing slides, so I don't want you to look at them any differently. And as a couple of our presenters have mentioned, UCLA Health is also a really complicated organization. There is actually no legal entity called UCLA. We are all part of the University of California, and so the fracturing of reporting lines happens right at the top. On the left-hand side, we have the health system, which includes our 4 separately licensed hospitals, the practice group, over 250 clinics. And on the right side, you have the School of Medicine. And in the middle, this, size-wise doesn't do it justice, are 17 clinical departments, which is the Department of Medicine, the Department of Orthopedic Surgery, the Department of Lab and Pathology Medicine, Radiology. All of these departments function pretty broadly like independent businesses. And that has had some really great effects. They've been allowed to be entrepreneurial and seek out new challenges, hire really talented individuals, which has made UCLA the organization that it is, but it makes it pretty complex as a result. And we'll talk about some of those challenges. So just, again, looking at the numbers from our marketing team, we are in the top 5 nationally, which means 5th, of course, according to the U.S. News and World Report. We've been on that honor roll for 33 years in a row. We have a little under 1,000 beds for adults, peds, and we have a psychiatric hospital, which is going to move in a few years. And we have a faculty that work at 6 different community hospitals around Southern California. What's also exciting, and I think a couple of folks have touched on this, is just the sheer amount of talented people that you can work with in an academic medical setting. The School of Medicine receives just under $1 billion a year in federally funded research dollars, which leads to attracting a lot of really brilliant people. Some of the achievements that I just kind of pulled off a slide where, researchers here described the first cases of AIDS. We also helped develop some of the tests that led to organ transplants and are now the top solid organ transplant center on the West Coast. I think we've done something like 8,000 kidney transplants and over 3,000 liver transplants. It's a big part of what we do. And we also pioneered the field of brain mapping. To be honest, I'm not even sure what that means. But I know that our vice chancellor was in the brain research program, so something to that. And just to give you some sense of scale, just picking a few numbers out, we have 3.1 million outpatient visits a year, which, to give you a sense of it, on any given day, over 12,000 patients visit one of our clinics. We have 65,000 emergency departments in just one of our hospitals, or visits in just one of our hospitals, so it's over 200 a day. We have almost 31,000 employees. So when you talk about a complex system, that's a lot of people. Here's just a kind of a map of where you can find us. And what I want to draw your attention to is one thing that I'm really excited about are these little bus-like logos here. About 2 years ago, a member of our performance excellence team here in the hospital worked with a group to develop a homeless healthcare collaborative, a van service that would go and treat our homeless population throughout LA County. He then left to become the director of that program. And they've gotten both private funding and funding from the state. We got a nice photo op with one of our congressmen from California a few weeks ago. And so you can see we are as far north as the Central Coast in San Luis Obispo, and how far west is Santa Barbara, and as far south as Irvine. So we cover a lot of ground. So why the healthcare industry? As a couple of us have touched on, we can offer stable jobs, good pay, as Professor Belson mentioned, pretty location agnostic. Of course, Zoom has transformed the way we work, but as you said, you can practice healthcare really anywhere. A lot of us have already mentioned the strong match of industry needs and skill sets, and I'll try not to belabor too many of those points. Some of the things that I wanted to focus on in this talk were the highly educated and really motivated workforce that we have. The fact that this work can be really fulfilling, both personally and to your community. And that you can, as John mentioned earlier, you can really contribute to health inequalities. And so as I was putting this deck together 2 nights ago, and caveats apply. I searched operational excellence on LinkedIn in the manufacturing sector and found 4,800 openings. And I also searched operational excellence in just the healthcare sector, and I found almost 9,000 openings. So a lot of opportunities there if you so desire. And then there we go. As Dr. Wu said, we have a lot of opportunities in terms of cost. Kaveh touched on this as well. Currently, we spend about 18.3% of our GDP on healthcare, significantly higher than other countries. When you take into account GDP per capita amongst industrialized nations, again, you see a trend line in the US up here all by its lonesome, spending significantly more than anyone else. So does that give us better results? No. You can see here we have a significantly lower life expectancy than other industrialized countries, which means, again, a lot of opportunity for improvement. A lot of folks already touched on the data here. I'll just point out one thing that some of our colleagues told me a few years ago when we were building some dashboards. Our EMR, which was made by a company called Epic, has up to 40,000 unique data points per patient. So let that just soak in for a second. That's a lot of data that could potentially be pulled, gets dumped into a very large data warehouse every night, which allows for a lot of opportunities to try to slice and dice that data. In academic healthcare, that means that we're doing a lot of research, which we can be a part of. And I think Epic has finally started to move into the 20th century, I'll say. If you're in other industries, you would be shocked still the struggles that we can have using data to make real-time decisions just because of the accessibility. But that is, as Dr. Belson said, starting to get a lot better. We also have a really motivated workforce. And these are two folks that I work with. That's Val on the right. She's a unit director in our geriatric unit in our Santa Monica hospital. And I just talked about how bad healthcare is, but it has been getting a lot better. As you can see, some old data, but some significant improvements in a couple different hospital-acquired conditions over the years. Val here worked on a project to help reduce falls. And as part of her commitment, they were trying to do after-action reports, but they were being scheduled when the nurse was back on service or on shift, and worried about other people's calendars. And on average, the delays were happening 1 to 2 weeks after the fall. And she saw their fall rates not really being impacted. So she committed to stopping whatever she was doing and debriefing on a fall or a near miss, and assigning someone to do that overnight and on the weekends as well, in order to help their unit combat the problem they had with falls. I also think it's worth kind of highlighting what this can do for you. So I can't see everyone now, but by show of hands, either physically or digitally, how many of us have worked in aerospace? I know at least a handful, right? And how many of us still get nervous when we fly? Anyone? Yeah, I see a few hands here. Yeah, me too. And I have to sometimes when I tell myself, or when I get nervous flying, like, hey, you worked in aerospace, you know how diligent people are, you know how regulated this is, how many checklists there are, and that kind of calm me down. But that's really the only kind of psychic benefit I got from working in aerospace. And again, that's just my journey. So what I wanted to tell you about was how working in healthcare can help impact your own community and your people. This is just a quick story. That mini fridge is just a generic image I pulled off the internet. But several years ago, a close friend, mother was coming in to have surgery for cancer. And my friend was going to spend the next couple of days in the hospital. However, at that time, she was also breastfeeding, and they didn't want to bring their child in because of potential germs. And so she needed to have a mini fridge to store her breast milk. And we have, a handful of them floating around the hospital that we can use. But it was something that she was really nervous about. And so She called me ahead of time, and I was able to check in with, some of my colleagues in patient placement. And when her mom got admitted, the mini fridge was waiting there for my friend, and that was just a load that we could take off of her. I've been able to visit friends who have had, valve replacements, who came into the ED with skull fractures, and being able to check in on your friends when they're kind of at their worst. It's a really nice thing to be able to do. Sorry. And as John said earlier, we can also really impact inequality. So if you've ever thought about, we've seen all this really burst of interest in EDI issues over the last several years. And if you've ever wondered, how you can make an impact, healthcare is a great way to do that. If you pick a demographic, and I've listed just a handful on the screen, if you pick an outcome, you will see wide disparities in those outcomes based on race, gender, as John mentioned earlier, social determinants of health. Just knowing your zip code, I can tell you how much likelier you are to be readmitted to the hospital, or how much longer you were likely to stay in the hospital. And that's data we weren't collecting very well even 3 years ago. And so it's a really exciting time right now to be able to use that data to better understand the impact that we're having on our communities, and the work that we still have to do. And of course, I don't want to ignore some of the classic, work that we do here. And my fellow presenters have highlighted some great projects. These are just a handful of examples. We had a really bad wait time in an orthopedic clinic. And one of the things we realized was they were batching appointment types, which led to a lot of variation in arrival patterns. So we used a kind of a mixed model approach, and we're able to cut down, along with a few other improvements, cut down wait times in that clinic by 30 minutes. For a clinic that sees 40,000 patients a year, that was a pretty significant win. We did some time and motion studies in our sterile processing department, which cleans all the instruments that are used in the OR so they can be repackaged and sent up for more cases. On the right here is an example of a value stream map. We found that when trauma patients were coming into our ED, if they were being admitted upstairs, there's a really long delay. And so by using this, value stream mapping approach, we're able to isolate the source of a handful of delays and cut that time down by like 70%. Down here on the bottom left is one of the more complicated process maps I've ever done. The current state process map started out with 17 swim lanes. The future state, we got it down to, I think, 13 or 14. What this project was about was clinical research. So again, we've been able to span inpatient and outpatient work, and now we've moved over into the School of Medicine side. And what we found was that some new software helped impacted our clinical trials team and delayed patients signing up for potentially life-saving experimental treatments. And over the course of about 2 years, we were able to shave 2 months for that time, from the time the trial starts until the time we're able to start enrolling patients. So it was a big win for the oncology group. And then, as Kaveh said, we don't just do kind of point of occurrence projects. I've been at UCLA for 12 years now, like I said, and then when I first started, we had some senior executives say, who's doing this in healthcare? And we could only find a handful of examples. Now, as Professor Belson said, any large system worth its salt is going to have some sort of improvement program. And through the years, we've demonstrated so much value that we keep getting asked to do more and more things, to the point now where we are a pretty integral part of our health system's annual planning cycle, setting of new goals. This year, there are going to be 3 goals that are being applied to every manager throughout the system to kind of drive alignment. And we've taken a lead in helping develop one of those 3 goals that's going to help us look at our patient flow and really kind of set the stage for success for the year. And then a pretty recent thing that we're doing Does anyone recognize this? This image to the right? I'm sorry.
QFD?
I don't know.
Polyfunction. No, I don't think so.
Question, Kendrick?
Yeah, this is Hoshin Connery. This is an X matrix. So we've been asked by a few departments to help them with their strategic planning, and have now, I think, run Hoshin Connery events with a lot of follow-up work with 4 different departments. Our psychiatric hospital, it's moving in a few years, our pathology department, and so to see this work get incorporated at that kind of strategic kind of vision setting level is really exciting, and I think one of the kind of the opportunities that is going to be available to industrial engineers more and more in the future. So I will pause there, go ahead and stop sharing, and just want to share with everyone that we might have an opening here later in the summer. So if anyone is interested, please feel free to reach out to me on LinkedIn, and we'll keep you posted.
Great. Jim, you want to bring up the slide set? We'll do just a couple. I have just a couple of quick little slides, and we'll open it for Q&A. Let me bring up my slides. Yeah, so I think we covered a lot of the points that we wanted to get across here in the diverse roles of industrial engineers, different jobs, positions, projects. One point here I wanted to mention, the last bullet there is, and I guess this kind of came out in John Franklin Sierra's talk, that healthcare is more than just hospitals. Been interested recently in senior living, had some student projects and assisted living facilities. There's a lot of different kinds of environments and businesses in healthcare. We haven't really talked about manufacturing, healthcare equipment manufacturing, pharmaceutical industry, a lot of overlap of various industries involved in healthcare. Want to go to the next slide? As I mentioned, as we've been mentioning, a variety of jobs available. It's a secure industry. It's not going to go away. It's going to be a long time before the United States gets close to the performance of other countries, and industrial engineers can help that. Oh, I wanted to mention that rarely do hospitals and health systems have a department called industrial engineering. Sometimes it's called performance excellence, performance improvement. So on the other day, there was the A3 department. IISE actually did a study 20 years ago of what do you call industrial engineers in healthcare systems, and they found 53 different department names. Management engineering, it's called different things. It's rarely called industrial engineering, but maybe that's changing. As I said, I saw some ads recently specifically for industrial engineers. You want to go to the next slide? Also wanted to mention, while it's a big employer, some studies have said healthcare is the largest employer in the United States and the largest employer worldwide. The advent of additional digital data has made industrial engineering even more appropriate. What to do? A couple people mentioned job opportunities, LinkedIn, other sources for job postings. Again, they may not be postings for industrial engineers, but they're still looking for the industrial engineering skills. I got to do a plug here. We have a new master's degree in health systems management engineering, which would equip you for the kind of jobs that have been described here. Also I wanted to mention that we've had the hospitals, go to the next slide. The hospitals we had speak here are fairly large systems like UCLA and Keck and so on, but smaller systems, rural hospitals, I've done a lot of work with rural hospitals. For example, there's about 40 rural hospitals in California. They also need help, and while they don't have a lot of positions available, they do hire people and do need industrial engineering. I hope this was informative, but maybe you have some questions. So you want to use your digital hand raise if there's questions or not. Or other speakers have a question.
Feel free to write in the chat or speak up.
I guess the question I have of John Franklin Sierra, you're in a little bit of an unusual position in terms of industry. How did you get there?
Sheer dumb luck, David. Kind of. I mean, it's one of those things. It's just a series of funny events that lead you where you are when you try to look back. And so funny enough, I can actually trace it back to your class in my master's. I don't know why, but against my better instincts, I took a unpaid internship at the VA West LA that you had made the connection with their process improvement program. What's it called? They have like a systems redesign,
excellence,
systems excellence, systems redesign program. I took an unpaid internship with them, which don't ever do that, engineers. Sorry, I'm sorry. Just that's just as a general rule, don't ever sell yourself short like that. But I did for whatever reason. It eventually resulted in a paid gig there, though. I met someone who was then the head of psychiatry for the department and did some work for him, some process improvement projects. Years later, he became the director of the LA County Department of Mental Health, and happened to be right around the same time I was graduating from my PhD. And I said, "Are you looking for help?" And he was, and that's all she wrote. And then it's been just a crazy ride ever since.
Excellent. I noticed there's one participant here. The name is familiar, Younghae Kim. I don't know if you want to speak, but and he just dropped off.
No, sir.
Oh no, you're there. You're not in a hospital, but also in a public health system. Do you want to tell us how you use some of this material, just briefly?
Yeah, it's actually a perfect time because I'm actually at a conference that has all the lean practitioners out here in Chicago, Illinois. And it's really funny because when you ask them about their background, probably 2% of the entire participants have industrial engineering background, and 98% probably doesn't. And I've been had the opportunity to be in not only in healthcare and public health right now, but in hospital settings before, health insurance, clinics, ambulatory care, and now also in a skilled nursing facility. And so there's so much opportunity within healthcare. And I'm in San Francisco right now, and the Department of Public Health actually has a hospital arm. It also has the skilled nursing facility arm or division. It has the primary care clinics. It has behavioral health. It has population health, COVID, emergency response. It's a very diverse team that we have. And so healthcare is so broad. And I think there's so much sections and sectors within the healthcare that you can get into.
Yeah, great. Okay, any other questions? Into the evening, we don't want to keep you any longer. James or Stella, do you want to say anything additional, or should we just wrap it up?
I mean, it was a great discussion. I learned a lot about healthcare. I mean, I'm in the healthcare sector, but I'm more on the medical device part, not in the treatment part. But this was actually really, really informative about like what my products do and go into the system of healthcare. And so it was really insightful. Thank you, all of you.
And just to wrap it up, if there's no other comments or questions, we will have the recording and we'll share that with those who signed up or who emails me and requesting for that recording. So if you don't want to be shown in those recordings, just let us know as well, preferably before the end of the week.
Okie doke. Thank you, everybody. Have a good rest of your evening.
Thank you so much, Professor Jingyi.